someone share my slides? So this discussion is about EGFR targeted therapy. We all know it started with gefitinib, erlotinib, and these first generation TKI, they were better as compared to chemotherapy, and later other molecules came after erlotinib, this dacomitinib, afatinib, and osimertinib. Next slide. So we know the lung cancer is the most common cause of the most common cancer in the world, and it is the most common cause of mortality due to cancer. Next. In both sexes combined, lung cancer is the most commonly diagnosed cancer. About 11.6% of people cases, and the leading cause of cancer death. Next. And these are the parameters which determine the choice of first-line treatment in advanced EGFR mutated lung cancer: progression-free survival, overall response rate, presence of brain metastasis, safety, toxicity, quality of life, and patient receiving subsequent therapy upon progression. Next. So osimertinib provided unprecedented improvement in PFS in the FLORA trial. So these are various studies of various drugs: gefitinib PFS of 9.5 months, erlotinib 13.1 months, afatinib 11 months, dacomitinib 14 months, and osimertinib 18.9 months. Next. And in progression-free survival, these are studies, different studies like afatinib versus gefitinib, 12 months. Stable brain metastasis patients are included in this. In dacomitinib study, brain metastasis patients were excluded, and dacomitinib showed a better PFS as compared to gefitinib. And in the FLORA trial, these curves were separate from the beginning, and stable brain metastasis patients were also included in this study, and cross-trial comparison without head-to-head comparative study. So this next slide. Early separation of PFS curves is shown by osimertinib only. Next. These are overall response rate with different molecules. Afatinib overall response rate of 70%, gefitinib 56%, and afatinib response rate was better as compared to gefitinib. Disease control rate 91% versus 81%. Duration of disease control 12.7 months versus 11.1 months. And in the Archer trial, dacomitinib versus gefitinib, the median duration of response was 14.8 months versus 8.3 months. And FLORA trial, response rate of 80% versus 76% with gefitinib, and complete response rate of 3% versus 1%, partial response of 77% versus 74%, and duration of response 17.2 months versus 8.5, so nearly double. Next. Osimertinib has shown the highest response rate and the median duration of response. Next. So this is the overall survival data. Median survival with osimertinib 38.6 months versus 31.8 months with gefitinib. So this is the first study which has shown comparison between two EGFR TKI, gefitinib versus dacomitinib, and gefitinib versus osimertinib, which has shown a survival difference of about 7 months. There is another study, gefitinib versus dacomitinib, in which dacomitinib has shown a survival difference of few months versus gefitinib. Next slide. And median overall survival of more than 3 months. This is a Lux lung trial and the Archer 1050 trial. In this, afatinib failed to show the improvement in overall survival versus gefitinib. And in Archer trial, overall response rate was not statistically significant, and hence formal statistical hypothesis testing for OS cannot be done. Next. These are guidelines. So all these guidelines, NCCN guidelines, ESMO guidelines, Canadian guidelines, they mention osimertinib as the first-line treatment in EGFR mutated lung cancer. Next. And 28% of patients with on osimertinib, they were still receiving osimertinib at 3 years, and 28% of the patients, 22% versus 5% of patients still on treatment at the data cutoff. Next. And osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease status. This is the left side graph is for patients with known or treated CNS metastasis. Median PFS of 15.2 months versus 9.6 months. And patients without brain metastasis also, they had PFS benefit of 19.1 months versus 10.9 months. Next. Intracranial CNS progression. Median CNS progression not reached versus 13.9 months. And the hazard ratio of 0.48. Next. So intracranial or CNS response was not assessed in the Lux Lung trial, and patients with brain metastasis were excluded from the Archer-Dacomitinib study. Next. Safety, grade 3, grade 4 adverse events with Dacomitinib reported in 63% patients. Grade 3 or 4 adverse events with Afatinib were reported in 31% patients. And grade 3 or 4 adverse events with Osimertinib were reported in 18%. So among these, Dacomitinib, Afatinib, Osimertinib has the best safety profile. Next. Grade 3 and grade 4 second and third generation EGFR TKI toxicity. In Lux Lung trial, skin toxicity 9%, paronychia 2%, diarrhea 13%. In Archer study of Dacomitinib, 14% skin toxicity, grade 3 or 4, 7% paronychia, and 8% grade 3-4 diarrhea. In Flora study, the toxicity is very, very less. Grade 3-4 skin toxicity in 1% patients, paronychia in 1%, and diarrhea in 2% patients only. Next. And dose reduction in Lux Lung trial, adverse events leading to dose reduction were more frequent in patients receiving Afatinib compared to Gefitinib, 41% versus 1.9%. In Archer trial, 66% versus 8%. In Flora study, 4% versus 5%. So all these, they show that the toxicity profile of Osimertinib is much favorable as compared to Dacomitinib or Afatinib. Next. Quality of life, it was much, it is already discussed in the previous 2-3 slides. Quality of life is much better in patients who are taking Osimertinib as compared to those who are taking Afatinib or Dacomitinib. Next. And 1/3 of all EGFR mutated patients treated with first and second generation TKI are unable to receive second line Osimertinib. So as shown in this picture, 10 patients who are EGFR mutated mutation positive at baseline and who start Gefitinib, Erlotinib, or Afatinib as a first line treatment. About 73 to 77% of EGFR patients receive second line treatment. 30% patients, about 30% patients, they die during the first line treatment, or they were able to receive only palliative care. They did not receive the second line drug. And 60 to 76% patients can receive a valid T790 test result. So there are various reasons. One, the patient dies during the first line treatment. Second, patient goes for palliative care. He's in such sick condition that you are not able to test him. Third is about the 60 to 70% patients, they receive a valid T790M result. Other patients, about 30 to 40% patients, they do not have a T790 result. And at baseline, you do not know which patient on Gefitinib or Erlotinib will have a T790M mutation at progression. Next. And access to second line treatment. In IPASS study, 76% patients had second line treatment. In other studies, 48%, 72%, 88%. So approximately 1/3 patient, 20 to 30% of patients, they do not have access to second line treatment. Next. And real world evidence of T790 mutation after Afatinib. In a Japanese study, 43% of 37 patients acquired T790M after first line Afatinib. And in another study, 48% of the 42 patients who were rebiopsied after Afatinib failure, they had acquired T790M. And in another Taiwan study of 28 Afatinib treated patients, T790M was identified in 32% patients. Next. So less than 50% patients put on Afatinib acquired T790M. Next.
Sorry to bother, but you need to conclude, sir.
Okay. So sequencing of treatment is starting with first generation TKI. About 30% patients will not be getting second line treatment, and the best sequence for EGFR mutated patients is first line osimertinib. We have seen with the in the previous slide the gefitinib versus osimertinib. There was a 7-month survival difference, 38-month survival, overall survival, which is not seen with other TKI. Thank you. Thank you. So,
hello.
my talk is over.
Thank you, Deepak sir. It was a wonderful talk. It has been a long evening. I like